A very good afternoon, everyone. I'm Rohan Tripathi from iKnowCare Health of Solutions. Today, as we all know, is the 20th of May. This is the International Clinical Trials Day. iKnowCare Health of Solutions, as a part of its iKnowCare e-Academy, has been continuously bringing to you continued medical education classes and various lectures and webinars on health-related topics. So today we introduce Dr. Santanu Tripathi and Dr. Shambo Samajdar. Dr. Samajdar unfortunately has not joined us, is yet to join. He will be soon joining us. But we now have Dr. Santanu Tripathi to give the first lecture on the topic. Dr. Tripathi, are you there?
Yes, I am there, but I am struggling to share screen.
Just a moment. Dr. Tripathi, your screen is visible. Dr. Tripathi, kindly unmute yourself.
Am I audible now?
Yeah, you are audible.
Uh, Is the screen visible?
Yes, it's visible.
Okay. So, friends, today is the uh, International Clinical Trials Day. We all know, and we all appreciate that clinical trials is a extremely important strategy or tool in order to generate evidence that can guide clinical decision making regarding any kind of intervention, treatment intervention, any diagnostic, any medical device to come in the market or to be in the practice. We need to generate enough evidence, particularly in reference to their safety and tolerability as well as their efficacy. Once we are convinced about a positive benefit risk ratio, then only we can have the enough confidence to use such interventions. And particularly if it is a new kind of intervention which has never been used before in practice, then it requires the approval from the regulatory authority of the country. It becomes a newer kind of drug or device or diagnostic. Now, this strategy of clinical trials, it has evolved through decades and decades. As we stand today, it has been refined to a great extent since the time of some of the historical or prehistorical clinical trials that we know of. Okay, and particularly we would say that most of the uh, value addition has been done or optimization has been done around say 70 years back, when particularly after that second world war, the Nazi experiments that took place, and along with it there were lot of atrocities that actually took place, and after that there were good practices are to be put in place. So there were a series of reactive kind of steps which were taken, following which gradually over the next almost say 50 years, from starting from 1948, okay, to say 1996 or 7, over the next 50 years there were uh, continuous evolution of the clinical trial methodologies. And then even then in the last 20 years also there has been huge development in the methodology of clinical trials, and particularly we know of the more recent evolution in the form of the adaptive designs. Basically all these are on one hand to minimize the biases, on the other hand to increase the credibility of the data that are generated and the evidence that are created. We all also know about the evidence pyramid, and clinical trial is has a very respectable place, is considered to be a gold standard for evidence generation, and it has a place which is scheduled just below the systematic review and meta-analysis. So basically, the randomized controlled clinical trials are considered the gold standard in as an evidence for generation of evidence, and but then there is also a provision for evidence synthesis, and at the top of that pyramid, the meta-analysis is located, which helps in actually synthesizing the information that are derived from multiple clinical trials that might be happening for trying to answer the same or same research question by different researcher groups in different parts of the world. And with these kind of evidence synthesis exercises only, we can finally come out with a kind of decision which are applied in the different uh, treatment protocols, treatment guidelines, standard treatment guidelines, etc. They are developed. We all have overall broad idea of that. Now today we are going to discuss. In fact, there are two lectures today. The first was supposed to be delivered by Dr. Samajdar, Dr. Shambo Samrat Samajdar. He is engaged in some other commitment. He will be joining soon, but he was actually supposed to take us through how the clinical trials they have evolved over the last few decades, the history and its evolution, the good clinical practice principles. So he was supposed to talk about that, in fact. And my job is today is a little different from the usual kind of topics that we discussed on clinical trials day. I'm going to discuss this evidence to guide clinical decision making during the COVID-19 pandemic. We all know we are passing through this crisis, COVID-19 pandemic, for almost 1.5 year now, and we have lot of lessons in the last 1.5 year. It's a huge crisis on the mankind, and we cannot say that we are still out of it. We are just possibly, most probably, we have just been fortunate enough to cross the peak of the second wave of the pandemic in India, but then we never know whether a third wave is also awaiting us. So I'll be just trying to taking this opportunity of the challenges of evidence generation during the COVID pandemic. I'll try to also touch upon some of the inherent uh, constraints and challenges which are associated, and how we are or we should try to optimize them, and beyond the pandemic how we could utilize the lessons that we learned from our endeavor to find answer to many unanswered research questions during this pandemic. uh, how can we use this experience in uh, better using this tool of clinical trial in generating stronger evidence in the future time. So let us see how we can do justice to today's topic. The impact of the COVID-19 pandemic, if we consider, now there is a disease that actually caught everyone in the society unaware. Be it it's a disease about which we knew almost nothing, although there was some hint. Okay, the COVID SARS-CoV-2 infection in the 2002 2003 that we had experienced. Okay, so we had some little hint about that, but this time the kind of uh, havoc it has created ever since the month of December in China, and then it spread throughout the different parts of the world, and finally in India also we are no exception. So we are also passing through this crisis. This is a disease that has caught everyone unaware, whether it is healthcare administrators, the health scientists, the healthcare providers, the physicians, nurses. The public health experts, the health planners, and the policymakers, everyone, none of us had any clue about it. And it came so suddenly. Okay, so we could understand the problem very quickly, but then trying to find answer to that, a disease about which we knew nothing, how to diagnose it, how to treat, and how to prevent it, we had to learn at the expense of many casualties. As the pandemic struck, the medical fraternity as a whole was totally clueless about the nature of the virus, what type of virus. Although we knew that it is an RNA virus, and we could very quickly uh, do the genomic sequencing of this virus, understand the genome of the virus, and based on which, at least so far as the vaccine development early steps are concerned, we could have very meaningful step, particularly the different technologies for development of vaccine. So we could actually squeeze lot of time in the early phase of vaccine development. So that was a great advantage. But then we had to also uh, struggle to understand the nature of the virus, both physical and functionality of the virus, about the infection, how it is caused, how it is transmitted, okay, and how it spreads. So there were a lot of confusion. So finally, we there was a consensus that it is actually a droplet infection. But again, a couple of months back, it has been challenged again. It's not just a droplet. Yes, droplet may be the major route of, or major medium of transmission, major mechanism of transmission, but then one cannot also uh, rule out the possibility of airborne mode of transmission. So newer advisories are also coming in from that angle. How to diagnose the disease, and clinical diagnosis, how the patient would present, okay, the initial presenting symptoms, and then laboratory diagnosis. We had to also very quickly design the diagnostic or develop the diagnostic. Today we know that the RT-PCR is the gold standard for the laboratory diagnosis of the disease. But then it's not enough only the diagnosis. We need to also think of how the diagnostic test could be accessed, okay, equitably by all the people who need them. The pathogenesis of the disease, we had to understand the pathogenesis of the disease, and so that we can actually plan the development of the therapeutics based on that, identifying the targets in the disease, okay, and the clinical presentation of the disease, we gradually learned that. And then only we were also clueless about how to treat it. So there were some supportive treatment, symptomatic and supportive treatment, which was always required. But then, so far as the specific therapy is concerned, we had nothing in hand. So we tried with anything and everything that could have the faintest possibility of bringing some benefit. And in whatever way, the preclinical testing or some kind of observations which give some hint that it may be effective. So we started using anything and everything under the sun and tried to treat COVID pandemic. Some of them might have stood the test of time, but most of them have later on been discarded. So we are also unsure about the how the countermeasures could be taken. When you say countermeasures, the medical countermeasures and the non-medical countermeasures, both we are meaning. The public health countermeasures or the non-medical countermeasures, like the preventing the disease in terms of mask, in terms of the distance maintenance, in terms of the hand sanitization, etc., and also the uh, protection in terms of the immunization or development of vaccine, and treatment. So far as the uh, treatment or therapeutics are concerned, we all had to develop them. And as we are almost 1.5 year cohabiting with this disease, it still continues to baffle us. So every day we are confronted with newer information about the disease. and so much so that sometimes it has gone to the extent of people started suspecting that how is it that yesterday you told me about this and today you are just saying something which is in direct conflict with the whatever you have had told yesterday. But then you can't help it because it's a new thing and it's a very fast changing knowledge, you can say, and it is very fast evolving. So as newer things are coming in, so we have to also adopt them, knowing fully well that if tomorrow we know something, uh, something more reliable or something more dependable, something more credible, so we'll then actually start with that. So that's how it goes. Okay. So now we appreciate, after all this, after the experience in the last 1.5 year, that the research questions are also receding. Research questions are also not that we could set the research questions, say last year in January, February, and if we could solve those questions, we are better off. It's not like that. So newer research questions are evolving almost very, very frequently, so that we can call them living research questions or living research priorities. We need to understand the transmission and strategies to prevent such transmission. We needed to develop the laboratory diagnosis, okay, and the diagnostic services also, to facilitate the diagnostic services to be available to all who need them. The treatment of the disease, after we could understand the disease well, okay, its phases of progression, okay, the initial incubation period, then the viral phase, and then the inflammatory immuno-inflammatory phase, you can say. So and then there will be some unfortunate patients who can actually go into further critical phase, okay, because of the adverse impact of the different cytokines, which we call cytokine release syndrome or cytokine storm. Okay, so all these, when they became, there were some clarification on these, then only we could plan our strategy to better treat the patients, which kind of medicines could be effective in the early phase, which kind of medicines could be rather deferred in the later phase, okay, which medicine should not be used early because of the not acceptable or not very favorable risk benefit ratio. So all these very gradually we came to know. I give you just an example. Say, in general, steroids are not to be used in acute viral infections. But here is a situation where it is not just the viral replication that is causing all the problem in COVID-19. It is rather the post-viral phase, that is the inflammatory and coagulatory phase, which are actually causing all the trouble. So we people found that corticosteroids could be really a useful intervention, and later on it was proved to be so. But then again, corticosteroids had its own risk also. It is kind of a double-edged sword, and because it has the immunosuppressive property, so if it is given early enough, it can actually increase the viral replication, so which can have a otherwise unacceptable outcome. So therefore, it is also important when to use corticosteroid, and that also we have learned, okay, in a hard way. So now, of course, it has been more clear in the last few months, but otherwise, in the initial phase, I remember initial, say, 5 or 6 months, there were a lot of controversy regarding use of corticosteroids in managing COVID-19. Okay, so then came the vaccines. Thanks to our uh, strategy of the use of the different newer technologies in vaccine development, within a very short period, it could be discovered, it could be developed. The preclinical development was complete, and then there were uh, different kind of, you can say, adaptive kind of strategies that were taken for the clinical development, whereby the different phases, they were actually overlapped, okay, to so to say. And instead of waiting for a complete comprehensive completion of the phase 3 clinical trial, we could have minimum data that are required to have enough confidence so that it can be released for mass vaccination. It was done in most of the countries, and it was given a different connotation. Instead of a full approval, we had called it a restricted emergency use approval. And it was, I would say, revolutionary, particularly in Indian context, because this term or this phrase, that restricted emergency use, was not there, and even now it is not there in the new drugs and clinical trial rules. Although in spirit that provision is there, but this particular phrase is not there even now. But then we had made these at least two vaccines available in India in the early part of this year, okay, uh, 3rd January, and then from 16th of January, in the whole of the country, vaccination has started. Of course, right now we are passing through acute shortage of vaccines, but then we hope that very soon this will be uh, the scarcity of vaccine will be properly addressed, and we'll have sufficient supply, and then most of the people, if not all of the people, will be vaccinated at the shortest possible time. There are other public health strategies that were also gradually developed, in fact, and there has also been a lot of changes in those public health strategies, and all these changes or modifications that are taking place, also they are all based on the evidence that are being generated in parallel. One important thing must be mentioned here regarding communications. The best way to communicate these to the people, because it is a pandemic and there is a huge amount of anxiety among people, it is also important. It's not enough to have the drugs and vaccines and diagnostics in hand and the doctors to apply them, but we need to also gain enough public confidence, and for that is only possible through smart communication. And I find there is, this is in this area where possibly we are lagging a little, that the best way to communicate, the best strategy of communicating, and communicating in the most appropriate manner, in the most understandable manner for the lay public, for the general public, that is also an extremely important component in healthcare delivery in a pandemic situation, okay, for a pandemic disease. And finally, I would say that this COVID pandemic has taught us, we have learned uh, in a big way how the innovation, invention, and translation has been clubbed on one hand and has been accelerated, okay, at a very high speed on the other hand. So it was something which could never happen in a non-pandemic situation. So that also is a great learning, and maybe, God forbid, if we have to face another pandemic in another decade or in a few years, we will be possibly better off to actually handle that kind of a disaster as compared to the way we had handled it this time. So next slide, actually, I am trying to project how the World Health Organization started responding to this pandemic. We all know the first time in China, the first case was in China, and it was 31st of December 2018, sorry, 2019, that the WHO was intimated of the first case. China had intimated World Health Organization about the first case, and WHO actually took uh, uh, 1 month, a little more than a month, okay, and they could appreciate that it is going to take a very bad shape. So on 12th to 11th and 12th February 2020, WHO had convened a meeting like this, that Global Research Collaboration of for Infectious Disease Preparedness and Response, that is GLOPID R, or that was that WHO and this organization together, they organized a global forum on research and innovation for COVID-19. That is the Global Research Forum in short. There was a 2 day meeting. Uh, they used the research and development blueprint strategy as the framework, and the strategy actually aimed to coordinate and accelerate global research work to target the diseases that threaten humanity, develop diagnostics, medicines, and vaccines at a fast rate, and promptly respond to the outbreaks, thereby preventing epidemics. So, WHO actually took this opportunity to mobilize people and to develop a strategy not very specific for this disease only, but for any future uh, infectious disease which can have which can take the shape of an epidemic or a pandemic. So there are two types of goals. One is immediate priorities, and the second is the mid or long term priorities. I'm not going into those details, but this was a very important milestone event at WHO, which actually also coordinated, or which actually helped and facilitated the activities in different parts of the world. And just a month after, that is on 11th of March, WHO called this a pandemic. Okay, so thereby this title may not be very apt or appropriate, because in 2020 February, WHO didn't consider this as a pandemic. The term pandemic, or the declaration that this disease is now considered as a pandemic, that declaration was done on 11th of March 2020. Okay, now coming to some other aspect, that yes, we are very much obsessed with, we are very much disturbed with COVID-19 for the last 1.5 year, but we sometimes we have to also pause and think, ponder that how this pandemic has disrupted the overall healthcare milieu. So prior to COVID-19, people were also availing the healthcare, okay, institutional healthcare, the public healthcare, public health care system, etc. But as the COVID-19 came, because of its the ferocity, the people became had to respond it properly, but that response was also at the cost of putting other healthcare needs to the backseat, at least initially. So much so that these editorial was written. This was in the progress in pediatric cardiology. It said disruption of healthcare. This was in December 2020. Disruption in healthcare. Will the COVID pandemic worsen non-COVID outcomes and disease outbreaks? There was another. COVID-19 has disrupted India's routine health services. This was in September 2020. Disrupted India's routine health services, and that could have long-term consequences. And this is from the WHO, World Health Organization. COVID-19 continues to disrupt essential health services in 90% of countries, and this was in 23rd April to 2021, only a month back. Okay, so less than a month back, and that is uh, by World Health Organization. So people are concerned. This second round of World Health Organization's Pulse survey reveals that over 1 year into the COVID-19 pandemic, substantial disruptions persist, and about 90% of countries still reporting one or more disruptions to essential health services, making no substantial global change since the first survey conducted in the summer of 2020. So this is very important, and we should not lose sight of this. And there is a need to continue the research in other therapeutic areas also, and which has been to a great extent neglected and put to the back burner uh, for almost an year, or at least initial 6 to 8 months last year. Now I'll be talking a little bit about the specific challenges in conduct of clinical trials in general, whether it is COVID trial or non-COVID trial during the COVID pandemic time. And we all must have experienced, many of us must have experienced that suddenly when the pandemic came, there were good number of clinical trials were actually undergoing, were continuing, and they faced a lot of setback. And not to speak of the problems in initiating newer trials, newer clinical trials, new drug clinical trials. So all the stakeholders who are involved in clinical trial conduct, be it sponsor, be it site administrator, be it the ethics committee or the investigator or the patients themselves, so all of them had problems, faced problems, they had serious challenges. Like the sponsor, because of the lockdown, most of the staff, they started working from home, and so the site feasibility, site initiation, monitoring, all activities, all key activities were greatly affected. If you think of the site administration, the hospital where the trial is was being conducted or going to be conducted, so there also they had the priorities changed, and this became a very low priority, the conduct of clinical trial. Ethics committee, most of the members of the ethics committees or many of the members of the ethics committees, they were either unwilling or reluctant or not too comfortable to the adaptation that was required, okay, for continuing the ethics review process and participation in the ethics committee meeting, in the review meeting, okay, because most of the time or almost all the time throughout this lockdown period and beyond that also, even today, it is the holding online meetings became the new normal. So some of the members, they were not very much net savvy, and thereby there were issues. Besides, of course, the recording of the ethics committee proceedings, etc., there were huge issues regarding the participation or the involvement of the ethics committees. Similarly, when you talk of the investigator, they also faced lot of trouble, difficulty in the protocol compliance. There were huge number of rise in the deviations violations due to disruptions. There were compromise in the CRF filling. Challenged record management was another issue. So far as the patients are concerned, because they had to be homebound mostly, patients were also reluctant to travel or in self isolation. So it was difficult for most of the patients to undertake the required clinical trial activities. So we came across issues like, say, cancer trial going on, and the patient is scheduled to get the quota for the next uh, 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 to come for follow-up visit and receive the quota of the chemotherapeutic agent. Okay, uh, but then they couldn't travel, and so it had to be also organized. Talking to the sponsor, the ethics committee had to take the lead, speaking to the sponsor and arranging somehow delivery of the medicines at the doorstep of the patient, contacting with some local physician. So it was all most of these things are otherwise there is no SOP, or the protocol will not prima facie will not allow it. It will be considered as a protocol deviation. But then the fact remains that to conduct clinical trials in this kind of a situation, you need to also evolve SOPs quickly. Okay, and those SOPs now have become a part and parcel of most of the ethics committees, adapting the SOPs, accommodating the need of the hour, and adjusting the issues in continuing with the different key activities of the ethics committee or otherwise other stakeholders also. Even we have seen this, so far as the regulator are concerned, the in India, the uh, CDSCO and the Office of the Drugs Controller General of India, initial couple of months or 3 months, they were very sluggish, but of course very quickly uh, they could catch up, and they could also send circulars, okay, giving legitimacy to the alternative modes of operations, whether it is the role of the investigator or whether it is role of the ethics committee. So that was allowed, and to a great extent, very quickly, all the stakeholders, they started adapting themselves. So these were the challenges in the conduct of the clinical trial. But if we think of the specifically, if we talk of the COVID-19 clinical trials, they also had some special kind of problems with them. uh, we'll come to that. The other operational challenges are waiting signature versus digital signature, the different type of SOPs we are discussing, site SOPs, ethics committee SOPs, newer paragraphs or newer review of the by the ethics committee, alternative approval methods like email communication, etc., had to be considered and put into the SOP. Newer SOPs were developed, documentation, training, good clinical practice training, protocol sharing of the protocol, etc. The shipment of the investigational product and supplies, other supplies, the logistics management, site initiation, eligibility screen, informed consent process, the follow-up visits, quality assurance, quality control challenges. All these were to be looked into from a different angle, and necessary changes had to be made under the constraint situation. And there were newer chapters in the SOPs had to be created. When you talk of COVID-19 clinical trials, there were some unique challenges or specific challenges, starting from the patient PI eligibility, because this is an area where it is the anesthesiologist. If you think of, you are doing trial in critical care, COVID-19 patients in the critical care setting. In that case, you have to actually include the critical care physicians. Many a times they are actually anesthesiologists in our country, and the selection of the PI, and depending on, say for instance, you want to study a drug which might have effect in the early phase, and you are actually trying to see so long the patients are in home isolation, and the drug will be effective there. So there possibly you have to catch hold of the general practitioners, and that too these days, because of the telemedicine practices or teleconsultation, you have to also adapt yourself how best you can do that. Okay, data acquisition, handling paper documents, serious adverse event management is also another challenge. Okay, and addressing issues of eliminating biases, impact of confounders, and ethical issues like autonomy, beneficence, non-maleficence, and justice. They also find themselves in a different shape when you talk of conducting COVID-19 clinical trials. Now coming to another area, that all said and done, in this constant situation, whether we are actually generating good quality data or good quality evidence. Now there have been some literature on this, and people are saying that if you compare the methodological and reporting quality of COVID-19 and other research, people have done some work in the first during the first wave of the pandemic. And here you see on the left hand side of yours, this is the COVID-19 publications, and on the right hand side is the non-COVID publications, and this evidence pyramid that has been actually simplified a little. Okay, and here we have actually compared, they have actually compared the published COVID-19 and non-COVID research using the classical evidence pyramid, although it is a little simplified evidence pyramid hierarchy. And you see that system, the case report and case series, here it is 19%, and here in the non-COVID it is 2%. So there is a there is a tendency to have more case reports and case series during this COVID-19 research. And here you see the case control and cohort studies, observational studies, 32%, and on this side is 67%, more than double. Randomized control trial, 54% non-COVID papers, because of the inherent problem in designing and actually conducting, complying with the randomized controlled clinical trials. So we find mostly it is observational studies, and as we know, the quality or the strength of the evidence in observational studies are much less as compared to randomized controlled trials. And finally, when you talk of systematic review, and you see that on non-COVID papers it is 10%, and while in this case it is 2%. Now the choosing of these papers, okay, in a during a given time frame or the timeline, they have also done it most objectively, and there is the possibilities of bias in selection of the papers, they were minimized to a great extent. In this side the total sample size is around 100, and this side is say around 80 or uh, 90 around, I think. This is how much it will be, 13, this is 80, yes, almost 100. So in both sides the sample size is similar, and but then you see in each, if you compare, there is statistically significant difference in the type of the papers or type of the design, research design that has been followed, okay, in COVID-19 research versus non-COVID research. So it was an interesting finding. Rapid publication was also another issue, another problem. Rapid publications risk the integrity of science in the era of COVID-19. Yes, there was a need for hastening the research and hastening the publication. We all know that most of the time we had temptation of preprint, and but then preprint has its own inherent problem of not getting peer reviewed. So uh, so that is a inherent problem. So quality of the evidence or quality of the conclusion, okay, that can be again questioned. So that has to be also kept in mind. That is an inherent issue with the uh, rapid publication. On the right hand side, you see the pandemic publishing poses a new COVID-19 challenge. So this was a Nature Human Behavior paper, and this was in it was a recent, 23rd June 2020, and the other one on your left hand side, okay, okay, it was also 2020, okay. So, and here is another paper that shows that the decline of experimental paradigm during COVID-19 pandemic. Experimental paradigm is interventional studies, okay, clinical trials. So the quality of clinical trial in general, it is believed that it is not very strong. Okay, quality is not so good in general. Okay, as compared to the publications or the research that had been conducted in the prior to pandemic. So but then we learned from this, we had a compulsion that we have to deliver very quickly, but at the same time we have to take care that we should not compromise the quality of the evidence that we are generating, because otherwise the very motive for which we are engaging ourselves into clinical research, that will be lost, and ultimately the patient will not be benefited. Okay, so the benefit risk ratio will not be favorable. So this is another very important paper that we came across. Okay, as a consequence of this overwhelming catastrophe, long established prevailing medical and scientific paradigms have been disrupted. The response of the scientific community, medical journals, media, and some politicians has been far from ideal. Okay, in this particular piece of work, they have discussed the failure of scientific enterprise in its initiatives to address the COVID-19 outbreak as a consequence of the disarray attributable to haste and urgency. So this was, and from this, in this article itself, they have actually finally proposed this model, okay, whereby they had said that to divide all conclusions or the all evidences generated in the last 1.5 year into three broad groups or classes. The left hand side is the robust column, the type of studies which otherwise qualify to be placed in the robust basket is well designed and well conducted randomized control trials, findings replicated in independent randomized control trials, and findings replicated in three or more observational studies with adequate methodology to mitigate confounding. So then only they will be placed in this robust basket. In the middle, there is another basket which says the title of the basket is needs confirmation, where the methodologically weak randomized control trials, say for instance it is an open label trial, or there are good number of protocol violations or poor oversight of the study, so they will be otherwise put into this basket because they need further confirmation. So they may not be directly, no attempt should be made to directly translate the findings of these kind of trials or these kind of studies. Okay, if the observational studies without extensive replication, so then also it will need further confirmation. The preprints without peer review, they say that must not be or should not be taken at its face value. So you have to wait for the critical review process. And finally, press release needs confirmation. You cannot uh, start your translation based on the press releases of the expert opinion, etc. And the extreme right one is the basket, where the misleading or false kind of findings or false kind of knowledge, they are to be discarded. claims without the backup data, information based on expert opinion only, or information that has been proven wrong in the randomized control trials, or well designed and replicative observational studies. So they have also advised to use this color code proposal for grading evidence on medical news in the media, including social media. The color code fast check, the color code fact check would appear as a bar or logo on the top of the shared messages. Okay, so that's what they had proposed. And this I am projecting. This is a organization, the American Society. It is from America. Okay, and this is, they actually have done this assessment of evidence for COVID-19 related treatments ever since the inception. That means from early part of 2020 up to, it has been updated in up to 13th of May 2021. And you see, these are the columns: the antiviral agents, the supporting agents, and other agents. And almost all the uh, interventions that are used for the treatment of COVID-19, that has been covered in this document. And if you, these are all hyperlinked. If you click, you will uh, uh, go to the appropriate this thing, like this one. Okay, this is corticosteroid inhaled, and this has been recently updated. So if you click here, so you will go to, I'm sorry, it will not be possible here. So these are otherwise, if you go to this website and if you click it, you will be taken to the appropriate page. And it is a quite extensive kind of review, whereby they have tried to synthesize all different information whatever is available for that particular treatment intervention. And finally they have also given some kind of conclusion, what is the current status so far as this particular intervention is concerned. So that helps in translation and developing treatment guideline. So these kind of initiative has been initiated in different parts of the world. Like one important platform is actually COVID end. Okay, that is COVID evidence, E for evidence, N for network, D for decision making. COVID network, COVID-19 network, COVID-19 evidence, uh, evidence network for decision making in the in policy and for protocol development, etc. That is the thing, and that is in the McMaster University. And similar kind of network is also there in different European universities, and also in the United States. WHO has also continuously updating its COVID resource platform. So that also is very much helpful. So we all know that evidence-based clinical practice is the need of the hour, and the quality of the evidence and the strength of the evidence is exemplified in this evidence pyramid. But it is not just enough to have uh, the good evidence. You need to also apply that. That is what is translation practice of evidence-based medicine, where not just the best evidence but the clinical expertise of the person who is applying that evidence in the clinical setting is also important. And the patient values are also to be respected and given its due uh, respect is to be given to that. And then only the practitioner should be doing justice to the patient. And it is not that it is impossible even in a pandemic situation. Yes, there is a need for pressure of time, but at the same time we should keep in mind that we must not compromise with the quality of research based on which we'll be making the clinical decisions. Okay, so with this is basically a reminder to us that what we have experienced in the last 1.5 years during the pandemic, whether it is developing a diagnostic, whether it is developing different public health strategy, whether it is developing vaccines or the different therapeutics. So and then what kind of benefit it is accruing. So there is also a need of real world evidence generation. It is not enough that yes, we have done clinical trials and this is a very high quality evidence, so you go with this and apply in patients, but then how the patients are responding in the real life situation, that is also important. And that feedback will also help us as necessary to also modify the guideline, modify the protocol. Okay, and that may be the reason why uh, only a couple of days back we have seen that the ICMR has said that almost more than a year we were actually practicing the plasma therapy. Now it is being withdrawn. Similarly, today only WHO has again said about against use of remdesivir. So as the new information are coming, we have to accept that sportingly, and we should not suspect or we should not think of some other motive behind it. Yes, we should try to also critically look into it. What is the basis of these kind of changes, or in the position, that we must also try to look into and accept it. In science, nothing is static. Things change as we know newer knowledge. That new knowledge is to be also applied. With these few words, I think I can stop here. And this was the last slide. And uh, Dr. Shambo Samrat Samajdar must have come already, and he will be speaking on more specifically addressed towards the celebration of this day, International Clinical Trials Day. He will take us through how the clinical trials evolved, and then how it gradually developed the strategy of clinical trials, how it was refined slowly, and what is the good clinical practice, and how those principles of good clinical practice were applied. Okay, until today, how it has evolved. Dr. Shambo will be speaking on that. Thank you very much for your kind attention. Thanks.
Thank you very much, sir. So, is my screen is visible?
I think I have to undo.
It is not visible, sir?
Now it's visible.
No, I
So
think
you
I
can,
have to undo first, unshare first.
No, it's all right.
I
Dr.
can see.
Shambo.
Yes, I can see your screen. Yes,
okay,
it's
sir.
all right. Yeah, yeah, I can see your screen.
So,
Right. Go
thank
ahead.
you, sir. Thank you, sir. It is actually my honor to sit with my teacher, my guide, Professor Shantanu Kumar Tripathi, sir. And while taking classes, he told us, while teaching about clinical trials, he told us clinical trial itself, it is a subject. And this requires involvement of multiple disciplines. So really it is worthy to have a separate day to celebrate clinical trials. And we all know that why in the 20th May is special, because this 20th May 1747 there was a navy fleet of Britain. They actually patrols the English Channel, and that time the scurvy is thought to have killed more British seamen and than anything like in fighting the French and Spanish against French and Spanish arms. There is much lesser death of British seamen compared to what scurvy had done. So there was something they are searching something to cure scurvy, and there was a hypothesis like that scurvy was caused by some putrefaction of the body, and that could be cured through introduction of some acids. So Lind, Lind was there in the one pioneer naval hygiene conduct, and he was a surgeon met. So he had done the first study, and Lind recruited 12 men for his fair test, and Hello? Hello, am I audible? Rohan, am I audible? Hello? Rohan, am I audible?
Yes, you're audible.
Okay, sorry. So Lind had recruited 12 men for this test, and uh, there was 6 different treatment arms, and one arm he first included with that lemon and oranges. We know that orange and lemons are the richest source of vitamins, and other arms like cider, like vitriol, that means a diluted sulfuric acid, or some arms with garlic, mustard seed, like that. So the arms, which include 2 seamen who were allocated citrus fruits, they experienced the most sudden and good visible effect. So this was, we can say, the first clinical trial like that which is reported. And if we go through the James Lind library, that have left his readers a little bit in confusion about his recommendations while he write down the reports regarding the use of citrus in curing scurvy, but he is rightly recognized for having taken care to compare like with like. So that is very important, how he selected 6 arms. So that was the design which was he had made that time, that generally and uh, inspired the future clinical trial designs. So this is very interesting story, and that is why most probably we are now celebrating Clinical Trial Day, International Clinical Trial Day, every 20th May. And before Lind, there was one king, and this was mentioned in the book of Daniel in Bible. So this experiment was not done by any doctor, but done by one king named Nebuchadnezzar. He was a resourceful military leader. So during his rule in Babylon, he had ordered his people to eat only meat and drink only wine. So a diet he had believed that would keep them in sound physical condition. But several young men from royal blood who preferred to eat vegetables objected. So the king allowed these rebels to follow a diet of legumes and water, but only for 10 days. But when that experiment done by that king ended, what happened, what they found, the vegetarians appeared better nourished than meat eaters. So he was that king who permitted legume lovers to continue their diet. And why this experiment is important? Because this was the first times in evolution of human species that an open, uncontrolled human experiment that guided a decision about public health. So this is very interesting. So we know it was, we can see how many years back, but 2018, 2019 and 2020, we found many similar type of result, but obviously this was done in a more fashionable mode, more controlled mode, but the results are almost echoing the previous result that had been done by King Nebuchadnezzar, that vegetarian diet gives more protection in regarding the cardiovascular health. And again, if we come back to this gentleman, that is the Avicenna. So he had rightly mentioned in his encyclopedic canon of medicine some interesting rules for the testing of drugs, which is that I'm quoting from there: a treatment should be tested in a controlled environment. So this controlled environment is very important. Why? To reduce different confounding factors. And in this case, they particularly mention about how to exclude patients with complex multiple illness to understand the real effect of drug in one disease. So I am just giving one example of this very interesting and we can say landmark clinical trial in recent days in diabetes, that empagliflozin CVOT. So while seeing the while reading this trial, we directly jump upon this result, and this result suggests that empagliflozin is giving at around 38% reduction in patient development of death from cardiovascular causes compared to placebo, reduce 35% reduction in hospitalization for heart failure, and so. But what is important, and this is not present in that publication in the NEGM, in the full paper, but you will find in the supplementary paper, the baseline characteristics. So to understand the result, to correctly interpret the result, it is obvious to see whether in baseline the groups are equal. So the same thing was told so many years back by Avicenna. So baseline characteristics is very, very important. Now, this was a first clinical trial of a novel therapy that was conducted accidentally. What happened? So Ambroise Paré, who was that? He was a surgeon, famous surgeon in Paris. So in 1537, while serving some army people for the treatment of wound, that wounded soldiers were treated by Ambroise Paré. So what he had done, he was just cauterizing the wound and putting some conventional oil to that. But what happened? After a few times, that oil finished. So he had some digestive solution which consists of yolk of eggs, oil roses, turpentine, like that. So he put that only without cauterizing and without giving that particular oil. So he was telling like that in his biography, that I could not sleep at any ease, fearing that by lack of cauterization I would find the wounded open, which I had not used the sage oil, and I was very much frightened that time, and I raised myself very early to visit them, when beyond my hope, but I found those to whom I applied that digestive medicament feeling little pain, their wounds neither swollen nor inflamed, and having slept through night, so they had a very good sleep. But the others to whom I had applied the boiling oil and cauterization, they were more feverish, they have much more pain, they have more swelling. So then he had determined never again to that use that cauterization, but using this digestive things, digestive oils. So this is one type of trial, clinical trial. And this concept is very, again, important. I am taking it from one dictionary, medical dictionary, what is placebo, because we always talk about placebo. So it takes the place of the actual substance and it is really bogus. But what is important to understand the real drug effect, the placebo has a tremendous role, and it was defined by Hoopers at 1811 that an epithet given to any medicine more to please than benefit of the patient. So this is very important concept, and from that concept the placebo appears, and this was first described by one United States physician, Austin Flint. He had planned the first clinical study comparing a dummy remedy to an active treatment. So he had treated 13 patients suffering from rheumatism with an herbal extract, which was advised instead of an established remedy. And in 1886, Flint described the study in his book named as a treatise on the principles and practice of medicine. Like that, this was given regularly, that particular plant product, and became well known in my words. And this is, he had explained like that, placeboic remedy for rheumatism, and that favorable progress of the cases was such as to secure for the remedy generally the entire confidence of the patient. So Flint's examination did not compare the two against that generally happen in any trial, but this concept was important. So from them the concept of placebo had started, and this was the first study which was published by A.M. Zelinek from Yale University, and they had used placebo arm, and this was the first study. So the C group is the placebo, and according to that they had compared. So this is the science which is evolving. And in 1943, this was again a very important year for the history of clinical trial. That was the time of Second World War, and a few years after, we all know the landmark discovery of penicillin. So one London biochemist reported that a group from the Royal Navy that had shown a product he had extracted from another penicillium named as Penicillium patulinum was beneficial in the common cold. So you can see the news spread to the other scientists, and it also came into the paper also. And there are some headlines. I had not found that particular headline, but in literature it was mentioned. The headline is like that: more valuable than penicillin, a question mark. So here you can say new cure for colds coming soon. So it creates a havoc, enthusiasm in the common people. But at that time, the time of war, they had conducted a controlled mass trial, and with the help of this lady, John Faulkner, as a coordinator, there was over 1,000 of office and factory workers were included in that study. You can see some courtroom where some people were, the patients were sitting. And what happened ultimately, I am showing the data collection sheet. So here you can see the doctor and the patient were blinded to the nature of the contents of each treatment bottle. and to the code letter of for the treatment. So you can see the different codes are mentioned, and that is for the nurses. So special precautions were taken in addition to using 4 treatment codes like QRST. A nurse made the allocations in strict rotation in a separate room, filled the record counterfoil there, and detached the code level for the appropriate bottle, so which the patient retained throughout this trial. So before returning the patient to the doctor, and the statistician passed this as an effective random concurrent allocation of patulin or control solution to the participants, all of whom have we know that common cold people were included in this trial. But ultimately the result was that no protective effect. So they had mentioned, the MRC mentioned, we are very much disappointed with this outcome, because it was done rigorously, and this was a very well conducted controlled trial. But this is very important. Even a negative trial can give more information. And next is another important trial which gives us message how to conduct, or how to conduct rationally clinical trials, so that allocation. So this was published in British Medical Journal in 1948. Streptomycin treatment of pulmonary tuberculosis. So that time we all know that pulmonary tuberculosis had no treatment, only the rest. So this particular study determined whether a patient would be treated by streptomycin and bed rest, or by bed rest alone. And that was made by reference to a statistical series based on random sampling numbers drawn from each center by Professor Bradford Hill. So I am coming to this great man later, and his contribution. But what is important to note that in this particular study, they had used some appropriate numbered envelope, and that envelope was opened at the central office, and the card inside told if the patient was to be S or C. So what is S means streptomycin plus bed rest, and C means only bed rest. So patients were not told before admission that they were to get special treatment. C patients did not know throughout their stay in hospital that they were the control patients. In fact, the doctors who are providing treatment, they are also not know which patient is getting streptomycin. So this was a landmark trial, and we can say this particular trial showed many important messages to clinical trialists how to conduct future clinical trial. So this was the first randomized control trial, and this is Sir Austin Bradford Hill. So few important concepts that came up: how to systematically enroll, what should be the enrollment criteria, how to collect data, how to use this allocation concealment. So we all know that allocation concealment is a technique used to prevent selection bias in different randomized control trials by concealing the allocation sequence from those assigning participants to the intervention groups until the moment of assignment. It prevents researchers from maybe unconsciously influencing which participants are assigned to the intervention or control group. Apart from that, this particular study, Dr. Hill had used some important parameters, objective measures, such as interpretation of X-rays by experts who were blinded to the patient's treatment assignment. So this was very important and very important to increase the internal validity of any clinical study. So what Sir Bradford Hill mentioned, why he had so much stringent about that. So he had been anxious that physicians would be unwilling to give up the doctrine of anecdotal experience. So this was the thing that had been done by Sir Austin Bradford Hill, but which revolutionized the clinical trial in futures. So apart from that, as we are doing human research, so we have to be very much ethical. So there are multiple atrocities happened in clinical research. I am not going in details, but I just want to mention these are the important atrocities. These are the hammering to our knee, so that we have a good knee-jerk response, and that good knee-jerk response are some important ethical codes like this: Nuremberg Code at 1949, Declaration of Helsinki, Belmont Report, and Siom's Report, like this. Among that, these are the three important points for all clinical research, ethically sound clinical research. So respect for person, that include autonomy of individuals and special protection for those with diminished autonomy. Beneficence means maximize the possible benefits and minimize the possible harm. And justice means there should be an equitable distribution of chances, so that subjects should be selected fairly to ensure that benefits and burdens of medical research are evenly distributed. And 1990s, the decade of harmonization, and we all know the place of Tintin, the Belgium, the Brussels, the capital is Brussels. That was the place where International Conference on Harmonization of Technical Requirements for Registration of Pharmaceutical for Human Use was first time conducted. The primary participants were USA, European Union, Japan, and there were some regulatory and industry representatives, observers like Canada, Australia from Nordic countries, and WHO act as a facilitator. So GCP evolved. So good clinical practice. So good clinical practice is nothing but good clinical research practice. So we all know that this is the standard for design, conduct, performance, monitoring, auditing, recording, analysis, and reporting of clinical trials that provides assurance. Number one, the data and reported results are credible and accurate. Number two, the rights, integrity, and confidentiality of the trial subjects are protected. So GCP equal to quality data plus ethics. And ethics is not only something very much moral. Ethics is equal to it is actually a multiplied product of 2M: morality and materialism. So morality should be there, along with materialism also important to be ethical. So bad science means a bad ethics. So what is quality data? That means the data and reported results are credible and accurate, reproducible in future. And what is ethics? That means the rights, integrity, and confidentiality of trial subjects are protected. Along with, also we had mentioned why materialism is also important for ethics. And this is very simple. Whether I am doing a ethical clinical trial, if I am just asking that, if I am just sitting as an investigator, I may ask myself that while I am sitting in the chair of my research participants, then will I do like same as I am now doing as a principal investigator? So long back, our ancestors taught us Atmana Pratikulani Pareshuna Samacharit. Do unto others what you would like others to do unto you. So if we can follow this principle, there is no question of being unethical. Now coming in clinical research, we all know that broadly it is an observational study, it can be, or experimental study. As we are talking about clinical trial, so it is an experimental study. So how we can understand whether I am doing a clinical trial or observational study? So first of all, if I am as an investigator, whether I am assigning the exposures to the research participant. If the answer is yes, then it is an experimental study and it is trial. So as an investigator, I am assigning my research participants whether you will take empagliflozin or you will take placebo, then I am doing the experimental study. But as an investigator, if I am just observing, the patients are getting either empagliflozin or some other drugs. I am just observing. So that is observational study. So I am not assigning their exposures to drug. So first question we should ask, that did investigator assign exposure? If it is yes, then it is experimental study. If it is no, then it is observational study. If it is experimental study, then whether the allocation is random. If it is yes, it is randomized control trial. If it is no, then non-randomized control trial. And when in case of observational study, whether there is some comparison between groups. So as Dr. Lind has done, so there is a comparison. So yes, it is analytical study. So I am not, please, I am sorry, Dr. Lind himself assigned exposure. So that is a experimental study. I am just giving one example that if in a study there is some comparison group, then it is an analytical study. If there is no comparison group, that is descriptive study. Then we have to see the direction, and that if the exposure from exposure to outcome, then cohort, from outcome to exposure, then case control, and exposure and outcome at the same time, then cross-sectional. There are some other in details we are not going in today's discussion. So the clinical trial, by definition, any systematic study of a new drug or an investigational new drug in humans. So this is a study in humans as we are talking about clinical trial. What is the purpose? To generate data for discovering or verifying its clinical, pharmacological, that means detailed pharmacodynamic or pharmacokinetic, or adverse effects with the objective of determining its safety, efficacy, or tolerability. So that is clinical trial. And these are the different phases of clinical trial. Phase 1, they generally, when investigational new drug application approved for testing in human, so we have to do first phase 1 clinical trial. The primary objective is to see the safety. Very less number of participants, maybe sometimes 5 to 10 or sometimes 20 to 100 participants, but 100 participants is much more number. Generally it is within 50 participants phase 1 trial done. Then the phase 2 clinical trial, In phase 2, the dose finding happen, at what dose the drug can act, and also to see the safety. In phase 3, broadly we need to see the efficacy of the drug and also along with safety. Then we have to submit for new drug application, and then when DCGI approve our drug, the drug came into the market, then we have to see the post-approval clinical trial, that can be phase 4 clinical trial. So these are the different phases of clinical trial. As we had started with history, and in the history portion we had not mentioned anything about our Indian history, but we Indian have a very enriched history like any other areas. So Ayurveda has a very past history of this type of clinical researchers, and they have a combination of both ethics and nyaya, that means logic. So philosophical teachings they had named like Vaisheshika, and logic, that is the nyaya. So they had used these two in together, and they were trying to generate evidences at that time. So they're 2nd century BC. There are they had done those studies. So we are also doing, we Indians also doing clinical researches. And thank you. And this was the sloka, I think, which is very important while doing clinical trial. As a researcher, as a research participants, I don't know whether the sponsor will agree with this type of sloka, but at least as a clinical researcher and research participants, we should understand the meaning of this sloka, that karmanne vadikaraste ma phaleshu kadachana ma karma phal heturhu ma te sangasta karmani. That means while I am participating in clinical trial, I should not have any aim like that I am getting benefit, I will be getting benefit as a research participant. As a investigator also, I should not have any bias regarding the outcome. So anything can happen. Only what we should do, we should only do our work. So we have only one duty, to carry out our research work. What happened in the result, that will we can check in future. So thank you once again. Thank you, Rohan, for giving me this opportunity. Thank you very much.
Thank you so much, Dr. Shambo, for being with us today. Doctor, it was great to hear from him and Dr. Tripathi. And the best thing was, I think, that even on this very important day, we never forget the human aspect of clinical research, the human aspect that Shamboda he referred to at the very end, that whatever be the result, the ethical aspect, the ethics of holding the research, rather than being more concerned on what the result would be, on the very beautiful slope of our ancient times. So I think that is as good a message as any with which we can sum up today's proceedings. If Dr. Tripathi would like a few words.
Sir, you
Dr.
have to
Tripathi,
unmute.
please unmute yourself.
Yeah, I think we have whatever we wanted to actually discuss in taking this opportunity of this sacred day. So we had done from our part, but I don't think there is any provision for spending more time in responding to queries, although I know there must be questions and comments also. I would request Rohan to allow the questions to come in the our WhatsApp group, and for the coming couple of days, if we receive questions based on whatever we discussed, questions and comments, we'll welcome them and we'll try to respond to them. It's already
But,
more than 1.5
but
hour. So
sir,
yes, Dr. Shambo,
I
if you have anything to say.
yeah, I have in this chat box I had found Mr. Amit Pachal had asked a very beautiful question, and I want
Yes.
to ask you also this question because you are the best person to answer this. That how to resolve ethical dilemmas in COVID vaccine trials who received placebo injection. So as you always taught us regarding that dynamicity of that pandemic, and with each time we are getting different types of vaccine, uh, the ethical dilemmas become changing. So when we are starting, maybe May 2020, there was some different types of aspect, and now it is in the November there is 2020 there is some different thing, and now it is May 2021 some
I'm
different.
calling you
So
back. I'm
please,
calling you back.
so may I
So
request you
as
to
we
please
understand,
elaborate
yeah,
this?
yeah, yeah, yeah. It's a very pertinent question. Yes, most of the time the vaccine trials, they are usually placebo controlled. So some people, they will be getting inert placebos, but at the same time, because the volunteer, most of the vaccine trials volunteers, particularly when you talk of COVID vaccine, they are followed up for a period of 6 months. And in the protocol itself, it is written that those who receive placebo at the end of the trial, so they will be also offered active vaccine. Okay, by that time, assuming that by that time the active vaccine will also come, so active vaccine will be offered to them. So that is also clarified in the informed consent document. Also, it is mentioned. The problem becomes a little more compounded when a vaccine trial, if a vaccine trial is conducted today, because so many vaccines have already come, there this becomes still more ethical challenging. Ethically, it becomes more challenging. But then you have to otherwise make it transparent and tell people that this is a placebo control trial, and there is equal opportunity, or maybe 25% possibility that you will be getting a placebo. But then at the end, maybe after the your participation is over, we can think of giving you an active vaccine, if it is not an open trial. So if it is a blinded trial, then again you have to wait until the blind can be broken towards the after the trial is over. Okay, but otherwise, if it is a uh, only when you get an opportunity to be out of the trial, then only you can be given an active vaccine. So that is done. That
Yes,
is taken care of otherwise. Yes.
yes, sir. Same thing. One thing just I want to ask you, sir, that at around January, maybe 20 January 2021, there was a recommendation, or we can say the advisory by DCGI regarding one vaccine trial, that is Covovax Novavax trial, to include a placebo group, which was not there in previous. But same very recently, the Sputnik V uh, got approval, and they had started their trial. Now they have two-arm trial, and they don't have placebo arm. So as the timeline is changing, so that placebo arm is also now going back because of maybe this type of ethical issues. So what is your comment, sir?
Yeah, that is true. But then, so long there was no vaccine, the ethical challenge of using a placebo was relatively less. But yes, when the active vaccines are already made available, then use of placebo is posing more ethical problem. And so, if the DCGI agrees to this, but then it is always good to have a placebo control trial because your data becomes more robust. But then if you have this if the I do not know really what is the design of the Sputnik V trial. If the DCGI has allowed that it will be both the arms will be getting active vaccines, so be it. Then it's good that at least both the all the participants will be receiving some active vaccine. So
Yes,
there
sir.
is,
They
but
had made that.
otherwise, scientifically speaking, so far as the data credibility is concerned, a placebo-controlled trial confers greater strength or greater robustness to the data. Okay,
Sir, specifically to the efficacy.
specifically for the efficacy, right?
So if already the efficacy is, sir, we know about the efficacy from different previous trials, maybe in different countries. So we can cover that place without doing that placebo control thing. Am I right, sir? Just like in case of Sputnik
Yeah,
V, they had done already.
yeah. In otherwise, any vaccine, you must have also noticed in the pandemic situation and in the vaccine scarcity situation, government has also allowed that henceforth the anybody can directly import it. Okay, there is no question of any approval from India any further. So only DCGI's concurrence is. So you are evolving. The same thing could have happened 3 months back, but that didn't happen. But now, because of the situation, okay, the DCGI is also relaxing the regulation, or the government of India is relaxing its regulation, and now government of India has accepted that if we stick to only Covaxin and Covishield, it will be very difficult to vaccinate most of the Indians, okay, in coming 6 or 8 months time, or 1 year time. So if you allow other vaccine candidates also to come in India and some of the people can be vaccinated with them, then it becomes easier. So they are allowing, making it more flexible and not making it mandatory that any new vaccine, say Pfizer or Moderna, if they want to come tomorrow, okay, they need not have to create local data in the name of breathing study or breathing trial, etc. So that is the current situation.
Thank you, sir.
All right, all right. Thank you very much,
Thank you
and
so much.
also, yeah,
So it was a great session. I would also like to take this opportunity to announce that we have My Cool Guru as our digital marketing partner. We will soon be releasing some courses directly on My Cool Guru. It will be duly shared on both the InnovoCare Health Hub Solutions and My Cool Guru pages. So I would like to thank both of our speakers, Dr. Shambo Samrat Samajdar and Dr. Tripathi. And with this, I would also like to thank all our participants who have spent this nearly 1 hour 40 minutes with us on this very important day. Hopefully, today and in the days to come, this very good discussion will be heard by many more people. And we are always open for discussion at our community, that is InnovoCare E-Academy, IHS E-Academy. So with that, I would like to end it today. Good night, everyone. Thank you so much for joining. Thank you.
thank you.
Thank you. Good night.